So today's topic is acute sinusitis. Acute sinusitis, what we have to understand as a general practitioner is not all headaches are because of sinusitis. So our major role is to differentiate different types of headaches, and as an ENT surgeon we have to attribute and we have to treat only those cases, only those headaches which lead to acute sinusitis. So, what is sinusitis? Sinusitis refers to a group of disorders which is characterized by inflammation of the mucosa of the paranasal sinuses. So, as we see, paranasal sinuses is actually lined by pseudostratified ciliated columnar epithelium, and it has a property to carry out the secretions. All the secretions from the sinuses are going into the nasopharynx. So, whenever there is an inflammation of this mucosa of the sinuses, then there will be stagnation of the secretions. When there is stagnation of the secretions, all the symptoms are because of this pressure which is created because of the secretions are getting stagnated within the sinuses. So, there are how many sinuses? Frontal, maxillary, ethmoid, and sphenoid. Among these, frontal and maxillary sinus is very easily affected. How do we classify? By location, by duration. By location, as we all know, there are four sinuses, four groups of sinuses: maxillary, frontal, ethmoid, and sphenoid. So, by location, we can classify like that. By duration, you can classify into acute bacterial, subacute bacterial, recurrent acute bacterial, chronic sinusitis, and or acute sinusitis which is superimposed on chronic sinusitis. So the exact terminology is rhinosinusitis because the inflammation usually starts with the mucosa of the nasal nose, and then it leads on to inflammation of the mucosa of the sinuses. So, the exact terminology now what we follow is acute rhinosinusitis, chronic rhinosinusitis. So, acute rhinosinusitis, the duration is usually seen from 7 days to less than 4 weeks. Subacute is 4 to 12 weeks. Recurrent acute is more than or equal to 4 episodes of acute rhinosinusitis per year. Chronic rhinosinusitis is more than or equal to 12 weeks. So, what we have to understand is whenever patient comes with cold, common cold, and if it is with less than 7 days, then there is no need to treat with antibiotics. Only if it is more than 7 days, we need to treat the condition with antibiotics. Otherwise, it can just be viral rhinosinusitis and you can just give symptomatic treatment. So, less than 7 days, no need to give antibiotics. Now, what are the commonest microorganisms? So, as we see in the chart, it is Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. So, any condition, any ENT condition, if they ask about microbiology, these three are the main culprits: Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Even in CSOM, though in CSOM, Pseudomonas is nowadays seen more commonly when compared to other microbial agents, but for rhinosinusitis, it is these three, both in adults and children. Now, etiology, there are host factors and environmental factors. In host factors are immotile cilia syndrome or cystic fibrosis, or any anatomical abnormalities like concobullosa. Concobullosa is nothing but air within the middle turbinate. Septal spur. Spur is a sharp deviation at the junction of the cartilaginous and the bony portion, or paradoxical turbinates, where the position of the turbinates is inverted. Any systemic disease like diabetes or any immunocompromised condition. Neoplasms. Allergy or immune disorder. Allergy is again, it is a vicious cycle. Whenever the patient has allergic rhinitis, he is more prone to suffer with acute and chronic rhinosinusitis. Immotile cilia syndrome is again a defect in the cilia, a protein which is a defect in the cilia where it does not move and the secretions do not move easily. Cystic fibrosis, again there is a defect in the gene and sodium chloride channels are affected. Environmental factors can be bacterial, viral, or fungal infections, any trauma, any tobacco exposure. That's why, because of more of pollution and these traffic policemen or people who work in industries, they're more prone for acute and chronic rhinosinusitis. And any iatrogenic causes like surgery, nasal packing, and nasogastric tube, which is always a rare cause. So this is the cycle. As I told, it always starts with the upper respiratory tract infection or it is an acute viral infection. Upper respiratory tract infection will lead to swelling of the mucosa within the sinuses and that will lead to obstruction of the ostia. Ostia is the opening of the maxillary sinus. As we all know, the frontal sinus, maxillary sinus, they all open, but the frontal sinus, the drainage is dependent, it is gravity dependent. But in maxillary sinusitis, the ostia is in the medial portion and it's much above. So the secretions are collected within their secretions are collected down and they are not easily they cannot be easily taken out from the maxillary sinus. The secretions, they do not move easily from the maxillary sinus unless and until the cilia moves. So whenever there is mucosal swelling, the cilia doesn't move and then there is collection of the secretions. So there is reduction in the oxygen tension, it decreases the mucociliary transport and transudation of fluid into the sinuses. Sinuses are obstructed and that will lead to bacterial infection. So this is the cycle. There are major symptoms and minor symptoms. Major symptoms are facial pain, pressure, facial congestion, fullness, nasal obstruction, blockage, nasal discharge. Nasal discharge or mucopurulent discharge is the most pathognomonic feature of acute rhinosinusitis. So, any patient who comes with an headache but he does not have other symptoms like facial congestion, nasal obstruction, nasal discharge, so it can be ruled out that the headache is not because of sinusitis. There can be hyposmia, anosmia, purulence on nasal examination, and fever. Minor symptoms are headache, fever, halitosis. Halitosis is mainly because the nose is blocked and he is opening his mouth and he is breathing. There is fatigue, there is dental pain, there is cough, ear pain, pressure, fullness is because there is a difference in uh, the pressure. The pressure changes are different within the middle ear and the nose, and so the eustachian tube function is not appropriate. What history you should take, whether there are persistent symptoms of URTI. So this is very important. One episode of URTI does not qualify for acute rhinosinusitis. So there has to be persistent symptoms of upper respiratory tract infection. And physical findings. Physical findings, there can be associated spur or there can be collection of the collection of the mucopus within the nose, or if you look for tenderness. Okay, you have to look for maxillary sinus tenderness, ethmoid tenderness, and frontal. Sphenoid again is very difficult. So other radiographic studies, what can we do? In radiographic studies, we take a plain x-ray, plain x-ray of the paranasal sinuses. There you will there you will see opacification, mucosal thickening, and air fluid level. So this air fluid level is again very important in acute rhinosinusitis. Uh, Other tests like transillumination we don't do, this is obsolete. Sinus aspirate culture you can do, and nasal endoscopy is also diagnostic of acute sinusitis. So coming to individual, maxillary sinusitis. Maxillary sinusitis, the main etiology is dental infection. So as we can see here, the dental infection, the floor of the maxillary sinus is actually related to the upper molars. So any infection from there through the floor of the maxillary sinus can lead to infection. Any periapical dental abscess or oroantral fistula. Fistula means there is a opening both in the palate at the region of the molars and also in the floor of the maxillary sinus. So on X-ray PNS Waters view, what do we see? We see a air fluid level. This is the air fluid level which you can see, which is very characteristic of acute sinusitis. But in chronic sinusitis, there won't be air fluid level. There will be mucosal thickening and the edges will not be so smooth all around the edges. CT is actually the gold standard, and here again we can see the whole maxillary sinuses filled with mucopus. Occipitomental view. This is the view which you take for maxillary sinusitis. This is the most common question which they are going to ask. Waters view or occipitomental view is the commonest view which you take for X-ray paranasal sinusitis. So here, how you place the chin on the film, there is no rotation. Orbits and maxillary sinuses, they look symmetric, and close beam restriction that and clear air fluid level. Okay. So see, as we can see, this is the frontal sinusitis, nasal ala, this is the petrous ridge, odontoid process, and the maxillary sinus. This is how you can see corresponding to the X-ray. The nasal ala, the odontoid process, the petrous ridge, and then again we can see the maxillary sinus more clear than any other sinuses. Okay. So what is the treatment? Treatment is usually the first choice of drug is amoxicillin with clavulanic acid. Next is cefpodoxime. So amoxicillin and clavulanic acid, you should know the dosage. 90 milligram is too much. Actually how we calculate is 40 to 50 milligram per kg per day divided into 2 divided doses. Okay. So cefpodoxime again 10 milligram per kg per day, and then you can 2 divided dosage. So amoxicillin with clavulanic acid is the first line of drug. Cefpodoxime, cefuroxime, cefdinir, these are other line of antibiotics. Azithromycin can also be used, but mainly amox. So nasal decongestant drugs, though they are xylometazoline and oxymetazoline. These are the commonest decongestant drugs. Analgesics, you can use any paracetamol, diclofenac, anything you can use. Hot fermentation is also very effective for severe facial pain and facial pressure. This is the oxymetazoline, xylometazoline. The percentage is 0.05 in adults, which you must remember. 0.05 is the percentage in adults. And this is steam inhalation, which is very effective again. Frontal sinusitis. See, this is how we palpate for frontal sinus. It is in the medial end of the eyebrow. And what is the best view for frontal sinusitis? Occipitofrontal view. Occipitofrontal view. And here on CT scan, we can see the collection of mucopus within the frontal sinus. In case it is not reducing with this symptomatic treatment with antibiotics and all that, then we do what is known as trephination of the frontal sinus. Trephination means we make a 2 centimeter horizontal incision near the medial end of the eyebrow, just below the eyebrow, and from starting from the medial going to the lateral, we make a 2 centimeter horizontal incision. Then the floor is exposed and the hole is drilled with the burr. Using a burr, we actually make a hole. Then pus is taken for culture and sensitivity. And then one plastic tube is inserted and fixed. Okay. So in such cases, then we irrigate with the plastic tube, we irrigate the frontal nasal duct and we irrigate with saline. So all the frontal sinus is now free from mucopus. So this is known as trephination of the frontal sinus. Ethmoid sinusitis, again medial end of the eyebrow. So here on CT scan, this is where we can see the ethmoid sinuses, and if it is in this CT scan, again it is filled with pus, so that is known as ethmoid sinusitis along with maxillary sinusitis. Okay, this is the pathognomonic ethmoid sinusitis. The features are the same: facial pain, pressure, and nasal discharge, nasal blockage. These are the major symptoms. Other minor symptoms like headache, fever, halitosis, and all this. Sphenoid sinusitis, again very rare that we see a sphenoid sinusitis, but this is the sphenoid sinus which you can see on CT scan, and when it is filled with mucopus, then we term it as sphenoid sinusitis.